So, good morning and a very warm welcome to all. In today's IC, which is on my mistakes and my lessons, we'll be dealing with the case scenarios that we experience on a day to day basis where the plan is perfect, the procedure is perfect, the surgery has gone off very well, but still the outcomes are not as per the expectations. The patients are not very happy. So, we'll be dealing with the case scenarios, we'll be seeing our experiences, what should we learn from them so that we can manage the patients better and they are happier. So we start with optical calculation blunders in IOL calculation, and it will be presented by Dr. Reshma. She's from Narayan Netralaya. I hand over the mic to her.
Good morning, everyone. So let us talk about optical calculation blunders in IOL power calculations. So we have different optical media starting from the tear film, the cornea, the lens, the vitreous and the retina, and each of these media can induce some amount of aberrations and can result into some amount of prediction errors with respect to your IOL power calculations. So we'll go one by one and discuss one case scenario for each of these. So to begin with, you can see two case examples over here. One is one with a good tear film with no staining or with a regular ocular surface, and below that you see another bad tear film wherein you also see a poor repeatability of the keratometry readings and a distorted image which is formed. So a 56-year-old gentleman presented to us with diminution of vision for a period of 3 to 4 months, and he had grade 2 nuclear sclerosis and punctate epithelial erosions all over the cornea. The dry eye workup was also abnormal, with Shermer's being less than 10 at about 5 minutes, and so was the T-butt. Now when we did his biometry for the IOL power calculation, as you can see, it showed an astigmatism of 4.59 at 156. Now, if we would have gone ahead based on this and planned a toric IOL for this patient, we would have probably implanted a model of T9, which would have resulted into an overcorrection of his astigmatism. So this is using the same biometry readings wherein we get a T9 on the Alcon toric calculator because we planned an IQ for this, no financial interest here. But what we decided to do was we went ahead and treated his ocular surface first. So after treating the ocular surface, we repeated his scans after a month, and we found that his astigmatism showed 1.84. Now that is a significant change from what it showed previously when we didn't treat the ocular surface. And of course there was a change in the toric IOL model as well. It showed a T9, and that resulted into a better visual outcome. Now, keratoconus, other ectatic corneas, post-keratoplasty, irregular corneas, all these are extremely difficult IOL power calculations. And in these cases, in these treated eyes or in these ectatic corneas, what happens is that there is a change in the relationship between the anterior and the posterior corneal curvature. So this is a case example of a 55-year-old gentleman who presented to us with diminution of vision for a period of 2 to 3 months. He had undergone hyperopic LASIK 2 years back, and he had grade 2 nuclear sclerosis with a posterior subcapsular cataract. So how do we plan a IOL for this patient? So as we are all aware, we use the post-refractive ASCRS calculator, and the calculator essentially needs you to enter the atlas readings. But in case you do not have this device at your disposal, the calculator ideally does not allow you to use any other. So any other machine is not. You cannot use you cannot use readings from any other machine interchangeably in the calculator. So where it says atlas, you need to enter atlas. But what if you do not have an atlas at your clinic? So in our practice, we have seen that EKR works equally well because that gives you a cumulative anterior as well as the posterior corneal curvature, and it adjusts it and then gives you a value which is similar to that of your simulated keratometry reading. So you remain in sync with your IOL power calculation because those are the calculators are modeled for a simulated keratometry reading. But the EKR, since it also includes the posterior cornea, it gives you a better result, particularly in these treated eyes or in ectatic corneas. So what we do is we see the flat, steep and the mean K reading across all the 4 zones, and we see the variation. So here we see the histogram and we see how broad based the histogram is. Now suppose you want to plan a multifocal for this patient or an extended depth of focus for this patient, then apart from looking at the aberrations, we also suggest that you look at the EKR and you also see how much is the variability of the keratometry over the zones. So ideally, we go ahead with a ASCRS calculation, and we also use the Barrett True K calculator. Now the Barrett True K calculator is basically for treated eyes or for ectatic eyes. It lets you choose whether it's a hyperopic classic, a myopic classic, or a keratoconic eye. So the ASCRS calculator uses a large number of formulae, and it also gives you an average IOL power, the minimum as well as the maximum IOL power. This was another case example of a 40-year-old lady who was diagnosed elsewhere with an advanced keratoconus and presented with a cataract. She had a history of using scleral lenses for both the eyes. So as you can expect, there would be some amount of contact lens warpage in these cases. So if you see, this was the first time she presented to us, and since topography is mandatory, you can see the broad-based histogram showing a large amount of variability. So would you really plan a toric IOL for this patient, even if she needs one? So we decided to discontinue the scleral lenses for her case, in her case, and we repeated the scans after a period of 3 weeks. Now there are a lot of papers in literature who have suggested the use of high-power custom toric intraocular lenses for correcting high corneal astigmatism in keratoplasty and keratoconic patients with cataract, and they have said that they do well. Now, of course, all these groups have used different kinds of keratometry readings. So some have based their calculation based on the SIMK, some have used the TCRP. In our practice, in our institute, we rely more upon the EKR readings. So we discontinued the scleral lenses for her and we repeated the scans. The variability in the EKR was slightly better as compared to the previous, but now as you can see, I'll just quickly summarize. So as you can see, the EKR readings are almost 62 to 65. Now your normal calculator is not going to let you use a 65 keratometry reading. There's only one calculator which will probably allow you to do that, and that is the Kane calculator. Now the Kane formula was introduced in the year 2017. It's a relatively new formula, and it lets you use the keratometry readings up to 65. So we went ahead, planned a toric for this patient, and she had a good outcome as well. Now, when we come to the retina and the vitreous, there are changes in the estimation of the effective lens position, pupil size, and the role of angle alpha, and variability in the vault height of the IOL. Now, coming to now there are different formulae which use either the anterior chamber depth and the effective lens position to calculate your IOL predictions. Now, I'll just skip this part because we are all well aware of this. The visual axis, the optical axis, and the angle between the two is the angle alpha. This was a case example of a 70-year-old gentleman who presented 1 month later after cataract surgery, having a best corrected visual acuity of 6/6, but he was unhappy. So he had a large angle alpha when we did the eye trace. And so if at all it is a normal angle alpha and the IOL is centered, when the IOL is aligned with the visual axis, the quality of vision is going to be better as compared to that when it is misaligned. So this was another patient who was unhappy 1 month after cataract surgery, showing blurring of vision but being 6/6. So she showed a significant IOL decentration on the eye trace. If you can see, the angle alpha was almost 0.7. So similarly, there was a distorted point spread function on the eye trace and a poor contrast sensitivity. So that could have been the reason why she was unhappy. So this is just a summary of the same. Coming to the vitreous, a silicon-filled eye behaves differently as compared to that of your normal eye. And similarly, phaco-vitrectomy in case of gas tamponade. So we have had multiple literature studies wherein biometry in a silicon oil-filled eye has been seen. And similarly, if at all the patient has undergone an SOR removal, you need to calculate it differently. So this was a 25-year-old lady who presented with a diminution of vision for a period of 3 to 4 months. She was operated for retinal detachment, and it was a silicon-filled eye. So this was her biometry before, in the phakic mode, before the before the retinal detachment surgery. And as you can see, the axial length showed 33.96. Now, when we repeated the biometry in the SO-fill mode, the axial length showed 28. So that shows you that. You would have to rely upon the SO-fill mode when you're calculating, and that's a very common mistake which each of us may do. Thank you for your kind attention.
Thank you, Dr. Reshma. Any questions for Dr. Reshma? So I would like to ask you, when will you plan a toric IOL in KC, and when will you not go ahead with it?
Okay. So the most important thing is, if at all, toric IOLs in keratoconus are especially in advanced keratoconus, function primarily to debulk the astigmatism. We are never attempting to completely correct the astigmatism, particularly if it's a high astigmatism. But yes, you can debulk. It also depends upon if at all the patient has been a chronic scleral contact lens user and has been happy with it, then you can probably debulk the astigmatism to some extent, and for the rest of the remaining residual astigmatism, he can continue using the scleral contact lenses. So apart from all these factors, the patient-related factors, we look at the topography, we look at the aberration. So topography, as I said, we look at the variability of the EKR readings over 4.5 millimeter zone, or rather the mesopic pupil size, which is the most important. In these cases, the mesopic pupil size was 4.5, so we took the EKR readings in the 4.5 millimeter zone. So if it's an extremely irregular cornea showing, then we would probably, it's better that you don't go ahead with the toric.
Yeah. Thank you.
Thank you.
So next we have Dr. Sneha Sengupta, and she'll be giving a talk on PRK haze. What did we miss?
So, very good morning to all. PRK haze is a major concern because it results in patient being unhappy after an uneventful surgery, and very little is understood about it. So, I will be basically dealing with the perfect PRK protocol that has been published by us, which can be used by the clinicians in their day-to-day practice, and we can have a better outcome. So, PRK is the first excimer laser procedure approved by FDA, less destabilizing to the cornea, suitable in thin, steep and flat corneas. Then why did it go out of vogue? It's probably because of the severe pain and the corneal haze post-operatively. So let's recap wound healing post-refractive surgery. Under a normal wound healing condition, following the surgery, there's release of pro-inflammatory markers that cause activation of keratocytes. They get converted into myofibroblast and fibroblast, which apoptosize in time, resulting in a clear cornea with normal structure and function. But in altered inflammatory conditions post-PRK, there's excessive activation of keratocytes leading to formation of excess of myofibroblast and fibroblast that do not apoptosize in time, resulting in formation of an aberrant collagen causing haze. So we have published our work which shows that there's an indication of novel predictive factors that help that result in post-surgical corneal haze. We found out that higher PREX1 induced profibrotic factors in presence of TGF-beta that resulted in predisposition to haze. So we designed a unique approach wherein we studied the risk factors and then stratified patients on the basis of this risk factor to develop an algorithmic approach that we called the perfect PRK protocol to prevent and manage post-operative haze. So this is the risk scoring system involved in the perfect PRK protocol, which includes the OSDI. OSDI has a strong association with the corneal dendritic cell density, and which is an indicator of ocular surface inflammation. So high scores indicate high ocular surface inflammation, resulting in increased predisposition to haze. The second one is the vitamin D levels, which is strongly associated with high OSDI scores in dry eye. So it was seen that low vitamin D levels modulated nociception, increased inflammation of the ocular surface, resulting in increased haze and scarring. We also found out that vitamin D shows its anti-inflammatory beneficial effects by binding to the vitamin D receptors, and we found that there were reduced vitamin D receptors on the ocular surface in patients with dry eye. It was as a result of the hyperosmotic environment that degraded vitamin D receptors. So local vitamin D receptors was the real culprit. Our own data revealed that the patients with low levels of serum vitamin D levels had higher density of haze. We also found out that the impact of vitamin D receptors was there on the inflammation and haze impacted vitamin D receptors, and we found that in keratoconus, which is an oxidative stress condition, low vitamin D levels was associated with high MMP9, which indicated high levels of ocular surface inflammation. The next one was contact lens intolerance. Chronic contact lens use stimulated the cascade of pro-inflammatory responses, resulted in contact lens intolerance, which caused an unhealthy ocular surface and resulted in ocular surface inflammation. We also found out high levels of MMP9 and pro-inflammatory interleukins in the tear film of patients with contact lens intolerance. The next one was meibomian gland dysfunction, which correlated with the ocular surface inflammation, and hence high gland dropout and low T-BUT were given high scores, indicating high risk to develop haze. Working environment also had an important role, and because of correlationship between the ultraviolet radiation level and the incidence of late onset corneal haze after PRK. So finally, the risk scoring system divided the patients into low risk, moderate and high, with less than 5 score as low risk, 5 to 10 as moderate, and more than 10 as high risk. So we designed a stepwise approach to manage the patients undergoing PRK surgery to decrease the risk of development of haze. This is a regimen that we use on a day-to-day basis to prevent the PRK haze. Pre-operatively, patients with low risk, that is less than 5, are taken for surgery. Patients with moderate to high risk are treated with tablet doxycycline BD for 15 days, steroid eye drops tapering over 4 weeks, cyclosporin eye drops over 4 weeks, and vitamin D, if less than 10, are given treated with injectables, or otherwise they are treated according to the WHO guidelines. Intraoperatively, loose epithelium and excessive secretions indicate inflammation. So we put ketorolac soaked BCL immediately post-operatively, because ketorolac reduces pro-inflammatory markers and thus helps in optimizing wound healing. The post-operative treatment regimen includes use of steroids, that is low potency steroids like loteprednol, tapering over 8 weeks. Then sodium hyaluronate eye drops 2 hourly for 6 months, and vitamin D is treated according to the WHO guidelines. This is for low risk patients having a low risk score that is less than 5. For patients having a high risk score more than 10 are treated with tablet doxycycline 100 mg BD for 15 days. High potency steroids like eye drops prednisolone tapering over 4 weeks, followed by low potency steroids like loteprednol eye drops tapering over 8 weeks. Sodium hyaluronate eye drops 2 hourly for 6 months, cyclosporin eye drops BD for 6 months, and vitamin D is treated according to the WHO guidelines. So this prediction, examination, intraoperative treatment, post-operative treatment and follow-up, evaluation and chronic treatment, that is the perfect PRK protocol, helped us in managing PRK and improving the outcomes post-PRK surgery, reducing the incidence of haze. Thank you.
Thank you, Dr. Sneha. So if the audience would like to ask any question. Okay, so in which patients like you get clinically significant haze for a long term, they're steroid resistant, and they are responding to steroid with a high IOP. What do you suggest for those patients?
So we plan to reduce or change them to low potency steroids. We taper them faster and we start them on anti-glaucoma drops. Along with that, we increase the duration of cyclosporin and then we follow them up to check for IOP.
Yeah, thank you. Any tacrolimus involvement?
Only if the patient is not responding to cyclosporin, then we add tacrolimus. Initially, we don't.
Yes. Thank you.
Thank you.
I have one question. Which day do you remove the bandage contact lens?
So we see the patients every day post-operatively, day 1, day 2 and day 3. Generally they heal by day 3 and after the epithelium has healed completely, we remove the contact lens on day 3. We might change it every day if the patient is not very comfortable with it. Sometimes there might be a debris on it. So we change it if the patient is not comfortable or if we feel that there is a need to change. And otherwise we remove it on third day.
So there's no difference between the three grades for all the patients. It is
Yeah,
on day
it is
3.
third day. If they have not healed on day 3,
Then
then we
only.
call them up on day 4 and day 5 and remove them accordingly. We make sure that the epithelium has healed completely.
Thank you.
Thank you.
So our next speaker, I will just like to introduce Dr. Shilpa Das, and she's a consultant in Narayan Nethralaya in the Department of Cornea, Ocular Surface and Refractive Surgery. So she will be speaking on why lubricants don't work and the importance in dry eye. Thank you.
A very good morning to one and all. I'm Dr. Shilpa Das from Narayan Nethralaya, Bangalore. Today I will be discussing a very commonly encountered entity in our day-to-day clinic, that is dry eye syndrome, and why in many times the lubricants do not work. Ocular lubricants are sterile, hypotonic or isotonic buffered solutions that replenish the tear film. But is dry eye a simple tear deficiency? No. It is a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film instability, hyperosmolarity and ocular surface inflammation. So not only the diagnosis of the dry eye but also treatment and monitoring the response of the patient to this treatment leads to eventual cure. Now among the menu of treatments for dry eye disease, artificial tears, gels and ointments are at the top. And we look at general characteristics, effects, presence of preservatives, electrolyte composition and osmolarity and viscosity agents present in these lubricating eye drops. They include drugs like polyvinyl alcohol, povidone, the carboxymethyl cellulose and hydroxypropyl methyl cellulose, the polyols and the hyaluronic acid. Viscosity building agents such as carboxymethyl cellulose, hydroxypropyl guar, polyethylene glycol and sodium halonate augment the aqueous layer and transiently reduce the tear film osmolarity. Apart from these cellular derivatives and liquid polyols, we have dextrin and glycerin that increase mechanical strength as well as act as an osmoprotectant. Other osmoprotectant agents include trehalose and erythritol. Now lipid-based eye drops, these are not so common in India, but we see them in the international market. They are amphiphilic lipids and surfactants that fortify the tear lipid layer to inhibit excessive evaporation, improve tear layer thickness and reduce tear evaporation, resulting in superior prophylactic efficacy. So these are very important in the MGD cases. So which lubricant do I choose in my clinic? I have to decide the type of lubricant to use and the frequency for the patient. So for this I depend on many factors like the severity of dry eye, the kind of dry eye, tolerance to preservatives, cost factor and lifestyle of the patient. Severity of dry eye we determine through many ways. First is the Ocular Surface Disease Index or other questionnaires like dry eye questionnaire, speed questionnaire. Symptoms of the patient we can classify from grade 1 to grade 4. Several tests in the clinic as well as diagnostic tests, the most common being TBUT, tear meniscus height, the staining pattern, Schirmer's test, tear osmolarity, molecular markers and automated diagnostics like lipid layer interferometry and mebumin gland morphology. So once I know how severe the dry eye is, for more severe cases I will be using those that have a high residence time and high viscosity on the ocular surface. The type of dry eye, Very important to distinguish which kind, whether it's aqueous deficient or evaporative. Aqueous deficient will require more of higher retention on the ocular surface and a very higher viscosity, as well as those which are osmoprotectant, whereas evaporative dry eye will include something like a lipid containing eye drops. The most common entity we see in aqueous deficiency is a Sjogren's syndrome. Now here we know that for mild cases only artificial tear supplements may be enough. But for the moderate to severe cases, especially those with the associated connective tissue disorders, require topical as well as systemic corticosteroids as well as immunosuppressants. The non-responsive cases require additional therapy like lacrimal plugs, IPL therapy, autologous serum and or scleral contact lenses. Another common entity, the meibomian gland dysfunction. Mild cases, warm compresses and antibiotic ointment would do. But for the non-responding and severe cases, we need to use additional oral antibiotics, additional topical anti-inflammatory, oral fatty acids, thermal pulsation therapy and intense pulse light therapy. So in these situations, only lubricants are not enough. We need to address all these things. Tolerance to preservatives. A significant concern with long-term use is the presence of irritating preservatives which can compromise the ocular surface and worsen the patient discomfort. Earlier we had benzalkonium chloride, now we have shifted to polyquad and stabilized oxychlorocomplex which are less irritating. In the Indian scenario, cost factor is very, very important. I have seen many patients who seem the affording type, but then later on they say that they are not able to bear the recurring cost of lubricants, especially due to prolonged use. I went through some of the drugs and I see that the gels are more costly than the eye drops. This is in Indian rupees, and there is a positive steep when the range goes from the carboxymethylcellulose to the sodium hyaluronate. The lifestyle, very important. Even if we give a lot of lubricants to the patient and treat the dry eye, if the patient has a prolonged screen time, working in low humidity environments, especially late at night, or is a smoker or a chronic alcoholic, then your drugs will not work. So very important to address this. Now there's a very interesting paper published in 2014 by Dr. Moshedfar and group, a literature review of all the articles on dry eye and artificial tears published till that date, and they gave an algorithm saying that the initial treatment of dry eye, if it was mild, most of the authors used CMC and HPMC as well as sodium hyaluronate. If it was refractive, they would add the polyols, that is polyethylene glycol and propylene glycol. If the symptoms would persist, they would add gels, and ancillary options were ointments and liposomal sprays. So to conclude, what I look at while administering lubricants to patients would be the severity of dry eye, the type of dry eye, the response of the patient, compliance of the patient, the effect of the environment, and also mainly address the cause of the dry eye. Among the causes, address eyelid pathologies, address local and systemic inflammation, anatomical variations of the eyelids, nutritional deficiencies, and effect of external stimuli before saying that lubricants do not work. Thank you very much.
Thank you, Dr. Shilpa. Any questions for her?
I'll just ask one thing. Yeah. So, Dr. Shilpa, when do you suggest we investigate for secondary Sjogren's if they are not really responding to our treatment?
Mainly would be the systemic features of the patient rather than waiting to check whether the patient is responding to therapy. So it's basically history.
Okay.
History and your systemic evaluation, which you can ask whether the patient is having joint pain, skin disorders, or all apart from your regular diabetes and hypertension, which is more focused in ophthalmology compared to the other histories. And then also we can physically look for any deformity. Sometimes patient may not have, but then you may be the first one diagnosing. Otherwise, you start your treatment and not responding even for a month, or you see that the patient is having a dry skin, dry mouth, that's when I refer to a rheumatologist and start the systemic therapy.
And do you suggest starting the immunomodulators on your own or tapering, or always with a rheumatologist? What if we do not have one
the systemic always with a rheumatologist, but I do have some patients who refuse to go or do not go. In that case, I start by myself.
Because the compliance will be a little low to a second doctor.
Correct, definitely, I agree. And based on experience, we know that HCQs and methotrexate are the most common drugs, and tapering dose of Vizorone. So you can initiate by yourself and monitor the blood parameters like CBC, LFT every 3 months.
And how often do you suggest to follow up?
Follow-up depending on the grade of severity.
Yeah.
1 month for sure, and after that maybe every 3 months.
Sure.
Yeah.
Thank you.
Thank you. Thank you all.
So our next speaker is Dr. Ritika Malik. She'll be presenting on unexpected post-operative LASIK complications, the lessons learned. She's completed her fellowship in cornea and refractive surgery from Narayan Nethralaya, and currently she's practicing in Lucknow.
Good morning, everyone. Can you start it? Yeah. So I'll be speaking upon unexpected post-operative LASIK outcomes and how we learn our lessons, and we'll be projecting our own algorithm also, which we have devised. So let's see some case examples. So we have a 48-year-old female who underwent LASIK, complains of glare and astigmatic symptoms very commonly seen in our clinics after the surgery. Her unaided vision surprisingly was 6/6. Good quantity of vision, extremely poor quality of vision. Topography showed centered ablation, everything else was normal, but still she was not happy. There was no evidence of dry eye, we ruled that out. Second was a 45-year-old male who was status post LASIK again, blurring of vision for 3 months. He did have a refractive error when we were checking him, so it was very minor, but he did have a cylinder of -1 in his right eye, surprisingly. Also centered ablation, no epithelial changes, poor visual quality, DLI was normal, and dry eye was ruled out. So what do we do with these patients who are still unhappy after refractive surgery? So we devised our own study, which we were doing, and we devised an algorithmic approach to actually evaluate these patients and, just make sure that everything is screened. So our materials and methods, we have 4,000 patients who underwent refractive surgery, so it was a prospective interventional study. We went back and saw how many patients were also unhappy coming to our OPD. So we had 65 unhappy patients who underwent detailed examination, visual acuity, dry eye workup, orthoptics workup, contact lens trial, just to see if we have any residual errors. Aberration changes and lenticular changes were also seen. So exclusion criteria for our study was any retinal changes or actually any changes in true axial length change. So unhappy patients who come to us often complain of glare, halos, difficulty in night vision, starburst, general sense of unhappiness. You have done the vision correction absolutely well, but there's no satisfaction. So what can we do for these patients? We can take a detailed history of vision and rule out dry eye firstly. So when we saw in our cohort of 65, we saw that 22 eyes actually had dry eyes. So what we did for them was a clear-cut assessment of tear film, epithelial mapping, Schirmer's test, meibography, tear film breakup, everything was included in our study. So we still found that these 22 people had truly dry eye symptoms and problems. So treating this patient, so pre-treatment, this was their OCAS values, so it's an optical quality assessment analysis. So if you can see here, which is an OSI index, it corroborates with the visual index and also the visual breakup time. So if you can see, it's majorly in red, so that's a danger point for this patient. Post-operatively, if you treat with high amount of lubricants for a very long time, the patient will stabilize in a shorter period and will have lesser complaints. So ruling out dry eye, even in post-operative refractive cases or cataract cases, premium IOL cases is very, very important for these patients. So remaining of the 6 patients who did not improve with our medical therapy went for some advanced therapy. So my colleague Dr. Shilpa has already told that we need to do these intense pulse-like therapies such as iLight, EI, or we can go with these patients who have MGD with the thermal pulse-light therapy, which is the LipiFlow therapy. So next we come to screening the corneal topography. Now, if we do have a small zone or a decentered ablation, the patient has been referred from somewhere else or is not happy with the treatment there, you can give a contact lens trial. So in our study, we found that 3 patients did have a decentered ablation. So what can be done for these patients is given RGP trial, rigid gas permeable contact lens trial, improvement in symptoms Ask the patient to continue with the glasses or contact lens. Do not be trigger happy to recorrect the patient. Check your residual stromal bed. If there's no improvement of symptoms, we can check what is happening internally. See the internal aberrations, there can be some changes in the vitreous, there can be some changes in the lens. So some of our patients did show changes in the lens who underwent like cataract surgery or IOL exchange surgery, refractive lens exchange surgeries. So higher the PNS, take the patient for the lens-based approach, lower the PNS, then screen for something else, which is known as the orthoptics. So orthoptics changes is coming from the muscles actually and creating the internal aberrations and also contributing to the corneal aberrations. So if you see in our patients, we saw that 35 patients, which is actually a huge chunk, were problems of orthoptics, which were ruled out by NPA, NPC, which we could have seen preoperatively also. So a detailed orthoptics evaluation reveals whatever the patient is suffering from. Either it can be convergence insufficiency, accommodative excess, accommodative insufficiency, divergence insufficiency, or convergence excess. So in your OPD, you can have a RAF ruler, you can have basic trial frames which can show the accommodation or the convergence ability before surgery also. So all these patients who showed the 35 patients, most of them were convergence insufficiency. So we now know that it's a screen-based lifestyle what we are leading, and this is the most important and the most common cause which we are getting, followed by accommodative insufficiency, and then we do get some of the patients which are in the mixed category of fusional vergence dysfunction. So what can be done for these patients? This is what the orthoptics evaluation and the protocol which we follow. And most of the patients are in the myopic shift or they do have glare. So these patients, if they are normal, if they are absolutely okay, if their orthoptics is fine, you can plan for a recorrection. If they are not, then we have to give them an orthoptics exercise. So orthoptics exercise is a vision therapy. It can be in 2 or 3 phases. That means a home-based and also an office-based exercise where they are constantly monitored for the hours which they are being provided the orthoptics exercise. So this is in our department, which we are generally doing the orthoptics exercise for pre and post patients. So just a quick case example. So a 40-year-old male who underwent bilateral LASIK procedures and after 2 months came again with the same complaints of glare, night vision problem. Quantity of vision was good, quality of vision was poor, everything else was normal. Now what can be done for this patient? We just spoke about it. Our algorithmic approach tells check the orthoptics, check how the binocular vision is. So this patient had a true convergence insufficiency. Look at the spread function. So it's absolutely showing internal aberrations are very high. So either it can be contributed by something inside, which is the lens or the vitreous, which was absolutely normal for this patient. And then when we checked and we did the orthoptics exercise for this patient, it was absolutely nice. He was happy after the 2 weeks of office-based exercise, and he's still continuing it. So the patients presenting with the post-refractive surgery with complaints of glare and halos, always check the dry eye, always check components internally of lens-based procedures if to be done. And also, most importantly, check for the non-strabismic binocular visual anomalies. So these are the highlights of a study. We just have the next is an algorithmic approach, which I've already discussed. And before planning a recorrection, always rule out the rest of the things. So what the study adds is that it gives a simplified systematic algorithmic approach, and an importance of the orthoptic evaluation has been maintained in the study. Thank you.
Thank you, Dr. Ritika. Any questions for Dr. Ritika?
I have one question.
Yes.
Do you see patients who actually have some amount of residual or after regression, maybe a 0.5 or up to -1 diopter, post refractive surgery, refractive error, but also have some orthoptic issues? So if you treat just the orthoptic component, would that make them happier? Have you seen such cases?
So yeah, we do get, most commonly we do get such cases only. So after they come back after surgery, after 3 months or 6 months, they were initially happy. They're still happy with the quantity of vision. It's just that the astenopic symptoms are now overbearing on their lifestyle. So seeing the computer screen or looking at the lights at night driving is creating a problem. So the thing is that orthoptics helps to rule these things out before taking the patient again into the OT and convincing the patient of an error which is there. Orthoptics does help in that, and they do improve. So the CI patients, which are the convergence insufficiency or the accommodative insufficiency, that's very easy to correct because we can give them flippers, we can give them home-based beadrock test and everything. So they can do the exercises, they are compliant most of the time. A little bit of chair time, counseling is required to explain such a new thing, that we have done a surgery, now there's a muscle issue, and it's important to explain this pre-operatively. It always helps that you might develop something in the future. So, but they do correct. So if after the therapy, even after doing of 3 months of therapy, probably the patient is not improving, then we can suggest a surface-based ablation if the patient is ready for it, or a LASIK retreatment.
Right. So the complaints are more regarding the quality of
The
vision
quality
rather
of
than the
vision is,
quantity.
yes,
Absolutely.
most of the time the quality of vision is the poorest, and that creates a problem with the lifestyle.
Right. Thank you.
Thank you.
Okay. So our next speaker is Dr. Saili Shirodkar. She's from Narayan Nethralaya. She'll be speaking on cross-linking outcomes. Devil is in the details.
Good morning, everyone. So I'm going to be discussing the common post-cross-linking complications that we face and try to cover most of them, hopefully. So the first topic that we'll be discussing is post-cross-linking haze. The most important thing to remember here is that not all post-cross-linking haze is a complication. It could be a normal healing response because of the increased activity of keratocytes which is seen after cross-linking, and it needs to be differentiated from the irregular haze, which is what we need to treat. This is due to irregular cross-linking because of impaired LOX and collagen dysfunction, and this is what needs to be treated. Unlike the good haze, which is paracentral and restricted to the anterior stromal area, this tends to be central and tends to affect the patient's visual acuity. So the normal cause of post-cross-linking haze is that it decreases in intensity and usually reduces over the course of 1 year. And before we assess, it's not just the visual outcomes that are impacted by this haze, it is also the topographical outcomes. So before we label a patient as progression, it is important to note if the patient has any presence of clinical haze, because that can affect your repeatability. In our studies, we found that this repeatability is least affected with the Galilei. And a more recent study has also shown that the Pentacam AXL wave is also significantly impacted by haze when it comes to repeatability measurements. Can we predict or prevent it? So this topic was extensively covered by my colleague Dr. Sneha, so I won't elaborate too much on it, but these are the factors that we need to look into in most patients. And it is important to treat the allergies, reduce eye rubbing, treat local and systemic causes of inflammation, and the post-operative protocol as detailed by my colleague Dr. Sneha is what we need to follow in most patients. The second topic that I'm going to discuss is progression. So progression is defined as an increase in the maximum K reading of more than 1 diopters over the preoperative value. And most patients of keratoconus in our studies, we've noted that they have a decreased lysyl oxidase activity, which causes impaired cross-linking. And although cross-linking tends to stabilize this to a certain extent, untreated allergies, inflammation, eye rubbing can in fact reduce this further and lead to failure of treatment. So how do we proceed in these cases? Again, it is important to treat your systemic allergies, systemic factors such as low immunity, low vitamin D, identify the factors causing progression, and most importantly, imaging needs to be performed to assess if this is true progression or pseudo-progression. So we have epithelial mapping, confocal microscopy, and collagen imaging, which can help differentiate the true progression from pseudo-progression. Another thing that can be done is assess the levels of MMP9. So what we found in our studies is the levels of MMP9 is found to be a crucial factor in progression cases and in the pathology of keratoconus. So this needs to be assessed in the tier biomarkers, and the systemic factors such as the vitamin D, vitamin B12, and IgE need to be treated. So this is a luxury that we have at our institute, that we can assess biomarker levels for various biomarkers in our own customized kit. So usually we assess the levels of MMP9 before proceeding to surgery, treat it with topical anti-inflammatories, oral supplements, or procedural dry eye therapy, and then proceed to the surgery. Repeat cross-linking, when do we do it? So if you've documented a case of failure, look at the haze before commenting on the failure. Wait for 24 to 30 months to decide if remodeling and wound healing can result in a better outcome. And if it is still progressing, rule out systemic and local inflammations, treat the causes and reassess, and then go ahead with your repeat cross-linking. The third case that I'm going to discuss is treatment of thin corneas. So this is our 5-point management protocol that we usually follow, where cases with moderate keratoconus are treated with epi on cross-linking or intracorneal ring segments, and advanced keratoconus with scarring is treated with penetrating keratoplasty or lamellar keratoplasty. So, but how do you treat thin corneas that have no scarring? There are various options which are currently available, but all of them have their own drawbacks. What we follow is a more customized algorithm at our institute. So there is published literature which states that the biomechanical effect of cross-linking depends more on the UV on time rather than the total UV effluence. So we derived this calculator based on a number of formulae which was fed into an online software. And we devised this calculator which is freely available for everyone to use, where we enter the thickness and it gives us the fluence time. So this animation displays what is done exactly. So you have a case of advanced keratoconus. We measure the preoperative pachymetry. After performing manual cross-linking, repeat measurement is done. We perform cross-linking with riboflavin drops given for 20 minutes. And the pachymetry, the post-removal of epithelium, the pachymetry which is documented, that is what is entered into our calculator. So this gives us the UV on time, which was 7.2 minutes for this patient, which is what we went ahead with. So we've had good results with this protocol. We've had no loss of lines and significant flattening of the keratometry values. Densitometry values showed no significant haze, and there was no significant haze noted clinically. And also it was found to be safe in terms of the endothelial cell counts. The preoperative and postoperative value did not show any significant change. We also noted presence of demarcation line in 65% of the patients at an average depth of 295 plus or minus 71 microns at 3 months post-cross-linking. And most of our patients showed good outcomes. So this is the algorithm that we follow with our patients with thin corneas at our institute. And our software is freely available for everyone to use online. So I hope this was a comprehensive enough discussion for most cases we see that post-cross-linking. Thank you.
Thank you, Dr. Saili. Any questions from the audience for her? Saili, will you elaborate a little on our biomarker kit, just in brief?
Yeah. So we at Narayan Nethralaya, we have our customized biomarker kit, which is customized for the analysis of 8 biomarkers. So basically, we take the patient's tears with the help of Schirmer strips. We add our patent buffer, and the resultant fluid is loaded into a cartridge, which is loaded into an immunoassay. It is basically a customized form of ELISA. And the entire process takes a period of 90 minutes. The results are delivered within 90 minutes, and the results generated can then be presented to the patient. We can quantify the biomarkers in the tears and treat the patient accordingly as per the level of biomarkers which are present in the tears.
Thank you.
Thank you.
I have a question. So
Yes.
would you be doing this for all patients?
For most of our patients preoperatively, we collect tears and we assess the levels of biomarkers. If the inflammatory markers are raised in these patients, then the inflammation is treated preoperatively, and then we go ahead with the surgery.
Right. So this is for keratoconus who require cross-linking.
This is for keratoconus who require cross-linking. This is also for our refractive surgery patients. Again, the rates of postoperative dry eye and postoperative inflammatory conditions, if a patient has subclinical inflammation and you go ahead with a LASIK, the chances of a postoperative dry eye would be significantly higher. So we tend to treat that before going ahead with the refractive procedure.
Right. So after your treatment, do you repeat the biomarker?
Yes, we do a repeat assessment at 1 month.
Thank you.
Dr. Saili, so what do you suggest for clinicians who do not have access for the kit? Do we do something clinically in the OPD to see these patients? or do you recommend something else?
So obviously this is a luxury that we have at our institute. If it is not available, then your clinical assessment is what matters the most. So a comprehensive dry eye workup for every patient undergoing refractive procedures, I think, would be mandatory.
And also for keratoconus patients?
Yes, absolutely.
So just as a protocol, we should get dry eye workup?
Absolutely, absolutely. Because these conditions tend to aggravate post-operatively, and dry eye in general is a good marker for inflammation. So it needs to be done for every patient pre-operatively.
So would you give it more importance to the breakup time or the Schaumers quantitatively to rule out these inflammatories?
I don't think that it wouldn't be just one that is more important than the other. Both of them are indicative of a different form of dry eye. So I would give both of them equal importance.
Sure. Thank you.
Thank you so much.
So our next talk is by Dr. Thirumalesh. He is a vitreoretinal consultant at Narayan Nethralaya, pursuing his PhD by Maastricht University. He'll be speaking on lessons learned from missing macular lesions.
Thank you, Dr. Sneha. So, cataract surgery is a premium surgery because physicians now have set the expectations of the patient so high, and the patient is paying a premium price. So it's very important that one has to look before you leap, before you do a cataract surgery. So this is a case of a 48-year-old microbiologist who came for a cataract surgery, and had we not done a particular OCT, what can happen is that grossly this particular patient was being monitored, and if you don't look at the OCT very clearly, you can see that a foveal lesion like this could be missed. So it's not just important to just have a look at the OCT, but make sure that you take multiple sections, and if you see any problem at the fovea, you address it, explain to the patient that the expectations can be set at the level at what the fovea can provide. So what are the challenges that one would face before doing a refractive surgery, especially now cataract have become or classified into a refractive surgery, is that detect and document the macular disease. Only a classic 90-day examination as taught in our post-graduation days will not really help. So OCT becomes a very important investigation. Patients do have high expectations, and technical quality of the procedures and comorbidities have to be told to the patient. This is a very important algorithm. Make sure that you have documented the visual acuity, slit lamp contrast. Along with that, macular test is extremely important. One has to also look at the functions of the optic nerve before you go ahead with cataract surgery and set the expectations of the patient. If the media is too hazy, one can opt to do a Maddox rod OCT VEP. Current generations Webster's OCT can actually document good enough macular structure in spite of the cataract. So what is the role of OCT in cataract evaluation? It's a quick non-invasive procedure. It's an optical biopsy. It gives you a detailed cross-sectional imaging. So the evolution wise, you can see that the time domain OCT which was not very useful in cataracts has now gone forwards, and now we have this web source where you can actually image through very hazy media and get away with it, and tell the patient what's happening. So these are the commonly used protocols. You can do a 3D macular scan, volume scan, or to gain more sections through the fovea, you can do multiple radial raster scan, or you can focus on the areas where there is a pathology and do a line raster scan. So OCT provides this live histology. We all know the layers of the macula, so I'll not delve into that. We all know that these are the hypo and hyperreflective areas. The common pathologies that one should pick up are drusen's, PEDs, ERMs, CNVMs, disciform scars, which all appear hyperreflective on the OCT, and intraretinal fluid or subretinal fluid will appear hyporeflective. So this is a 3D volumetric scan which shows the interface, the retina and all its layers. One should also look into the average retinal thickness. This gives an insight into what kind of pathology you are dealing with. So when and whom should we image? When vision is not correlating, when patient has complaints of metamorphopsia, when you see that you need to document that there is a condition which is likely to progress and you want to tell the patient about that. So there are few pathologies where just observation and counseling is very important. That if you have a solar retinopathy, you are going to tell the patient that they might not really improve beyond a certain level. Patients like dry AMD need to be told that the disease might be progressive. MACTEL patients would end up with CNVM at some stage. Geographic atrophy is definitely progressive. Old vascular lesions might not give a high contrast vision to the patient. However, if you find that the patient has diabetic macular edema or interface disorders or CNVM or polyps, these are the patients who would require combined treatment along with cataract surgery. So let's take a common example of this. A patient of a VMT like this would definitely require cataract with vitrectomy, and these patients would do well after surgery. So these are a few examples where VMTs can definitely, you can counsel for a premium IOL but still get away with it if you do a vitrectomy along with it. So there are certain patients where you set the expectations not very high, because patients with ERM and lamellar macular holes, these are not going to end up in 6.6. So you tell them that although you're going to be better, but you're not going to be 6.5 like you end up in refractive surgeries. So even when there is a hazy media, current generation OCTs can give you a very good detailed evaluation of the macula. So this is a OCT of a patient where you can see that previously there was a laser PDR. So definitely these hyaloid condensations which end up with distortion in vision, the ERM might be responsible. It might not just be the nuclear sclerosis that you're operating for. So it's very important to tell the patient or counsel the patient that they might require a combined surgery to remove these ERMs. Sometimes there might be secondary ERMs which also require treatment. Now, when you see a bad ERM like this, set the expectations of the patient to a certain level that, in spite of a combined surgery, they might not end up with vision beyond 6/18. So there are various stages of macular hole where you can actually give them a prognosis based on, how we end up. PFT is another common lesion where the macula might look very normal. Except for a few hard exudate adjacent to the foveal zone, the patient might appear normal, but these are cases where they are going to end up with low vision as time progresses. If this is the condition, then you would want to tell the patient that they might end up with chronic therapy in spite of cataract surgery. They might require injections as and when it is needed as the disease is progressive. Now, macular edema has multiple associated pathologies. It is not just diabetic macular edema. There can be vascular occlusions, there can be CNVMs, there can be cystoid macular edema. One particular thing is that in spite of a good cataract surgery, patients might end up with this particular complication, which is the pseudophakic CME. So keep a lookout on that. If the patient is complaining of drop in vision in the postoperative period, this might be the common etiological variant. Another condition is myopic foveoschisis, where as time progresses, the schisis kind of becomes more and more, and it can cause decrease in vision. So one should keep the patient informed. So the common treatment would be to remove the hyaloid attachments so that the patient ends up with good vision. So I'll quickly show the study. Yeah. So it's important that one should incorporate macular OCT as a part of your cataract workup. So we did this study where we initially included about 3,000 eyes. What we saw was very surprising, that in spite of an experienced retina specialist examining the patient, about 683 eyes actually had macular pathologies. And macular OCT was very important in picking up these lesions, which amounted to 24%. So about in 400 eyes, the pathology was picked up clinically, but a good 300 eyes required an OCT examination to actually pick up these macular lesions. So the most common lesions that were picked up were AMD and ERM, followed by other interface disorders. So there are many other publications which showed similar kind of results. What we did was we updated our study, and currently we had screened about 14,000 eyes, and a good 24.47% of the patients had macular pathology, and treatment altered eyes were about 258. So it predicts visual prognosis, it helps in counseling and educating the patient, and an informed patient will always have a better expectation set, which will lead on to a good doctor-patient relationship. So preoperative OCT in premium IOLs is not just an option. It has to be a part of the examination. It has to be part of the documentation. It has to be part of your counseling, which helps in better outcomes. Thank you.
Thank you, Dr. Thirumalesh. Any questions from the audience?
Dr. Thirumalesh, in your study, the patients who were detected on STOCT were missed by clinically?
Clinically, they appeared normal. Many a times, patients who have parafoveal telangiectasia or patients who have early stages of ER, they are commonly missed on the clinical
Right.
exam.
So they were detected on STOCT.
Many times, on clinical examinations, you might find that the patient has an abnormal macula, but once you do the OCT, you just see that it's just a vitreous condensation which is not altering the foveal architecture. Many times you feel it is normal on the OCT, they were picked up to have vitromacular attractions.
Right.
So it's important that one does an OCT before going for cataract surgery.
Do you also advise prior to refractive surgery that all patients undergo OCT?
Refractive surgery patients are, predominantly younger. So OCT, in a way, we don't commonly do. We do a good peripheral screening in those kind of patients.
Right.
But if they have vision which is subnormal, OCT definitely helps.
Or probably history of retinal diseases in the family. So that could be one indication of screening.
Peripheral examination in those would help.
Would help, okay.
Macular pathologies are not very common until you have subnormal vision in patients with refractive surgery.
Right. Thank you.
Thank you. I would like to thank all of you and all my co-instructors for being along throughout the session. Thank you so much.